right, so today we're going to be covering perioperative. Okay, so let's start with pre-operative phase. So pre-operative essentially refers to before the surgery. But first, let's discuss briefly the types of surgical settings. So there are different settings where surgical procedures can be performed by the surgical team. Elective surgery is a pre-planned procedure. And then emergency surgery is performed in response to an unexpected urgency, such as ruptured appendicitis, which required immediate operation. You also have inpatient surgery, which involves the patient being admitted to the hospital on the day of surgery. And then you also have the ambulatory surgery, also known as same day surgery or outpatient surgery. So that's the ambulatory surgery, which basically it's a minimally invasive procedures like laparoscopic techniques or endoscopy. And usually these surgeries typically last less than 2 hours, and the patient can go home the same day without needing a hospital admission or hospital stay. Now let's discuss the nursing management during the preoperative stage. The preoperative interview is conducted either before or on the day of surgery in settings like clinics, surgery centers, or hospitals. Its main objectives are to gather medical history, including any allergies to medications or food, explain the surgical procedure in anesthesia, ensuring the patient understands what to expect, and evaluate the patient's emotional condition and preparedness, including their expectations for the surgery. Surgery, even minor, can be stressful and may elevate your patient's blood pressure or heart rate. Too much stress can affect and slow the recovery after surgery. How someone reacts depends on things like age, past health experiences, current health, and life situation. So use simple, clear language to help your patients understand and feel less anxious. Your job is to look for emotional stress that might affect recovery and share your concerns with the surgical team, and be ready to assess quickly, especially since many of these patients come straight from home. And the most common emotions before surgery are anxiety, fear, and hope. Feeling anxious before surgery is common and natural, often due to uncertainty. But high anxiety can affect thinking, decision making, and how well a person copes. It's often caused by not knowing what will happen or worrying about the outcome. Past experiences or stories from others can also increase anxiety. So, providing clear, simple information can help ease their anxiety. Let the surgeon know if the patient is very anxious or needs more information. Anxiety may also come from religious or cultural concerns, so always respect and document the patient's choices and beliefs. The most common fear is dying or becoming permanently disabled. These fears often arise after learning about the risks during the consent process. Other concerns include pain, changes in appearance, or test results. Hope is a powerful way patients cope with surgery. Ignoring it can hurt their mindset and recovery. So patients may look forward to surgery to heal, improve functions, or external life. So it's important to recognize and support their hope and positive expectations. To review the body system, ask clear questions to check for any existing medical conditions, current health issues, along with patient's history, help us decide which pre-op tests are needed. List all medications, including over-the-counter drugs and herbal supplements. Patients are often asked to bring their medications for accurate recording. Some medications can interact with anesthesia. For example, antidepressant may increase opioid effects. Blood pressure medications can cause low blood pressure during surgery. Diabetes medications may need adjustment due to stress and fasting. Antiplatelet drugs can increase bleeding risk. So we may ask patients to stop certain meds before surgery, depending on the drug and patient's condition. Patients on anticoagulation or blood thinners like warfarin, Xarelto, Eliquis need a special plan to, such as pausing them or taking alternative medications. Herbal supplements can increase bleeding risk, especially when combined with blood thinners. Asked about substance use like tobacco, alcohol, opioids, marijuana, because this can affect anesthesia and recovery. Chronic alcohol use may lead to liver issues, poor nutrition, and withdrawal risks. And share the full medication and substance history with the surgical team. They will decide how to manage medications before and after surgery. As about all drug intolerances and allergies during the pre-op assessment, drug intolerance causes unpleasant but non-life-threatening side effects. Examples of drug intolerance are nausea, constipation, and diarrhea. A true drug allergy can cause serious symptoms like hives or life-threatening reactions. Examples of true drug allergy are low blood pressure, increased heart rate, and breathing problems. Knowing this information helps the surgical team keep the patient safe and comfortable. So record all intolerance and allergies clearly in the patient's chart. If needed, make sure to place an allergy ID band on the patients on the day of surgery. Screen for latex allergy by checking for risk factors, skin reactions like rush or hives, breathing issues from airborne latex, any past signs of latex sensitivity, and higher risk for latex allergy includes people with frequent latex contact, especially healthcare workers, those with hay fever, asthma, allergies to foods like bananas, avocados, chestnuts, potatoes, peaches, or eggs. All patients must have documented history and physical exam, also known as H&P, before surgery, as required by the Joint Commission. The H&P can be completed before or on the day of surgery. It may be performed by any qualified healthcare provider like physician, nurse practitioner, PA, or anesthesia provider. The H&P also helps the anesthesia provider assign an ASA physical status rating from P1 to P6 to assess surgical risks. Outpatient surgery patients are usually rated P1 to P3. A full physical assessment should be done before surgery, and review and document all findings and report any concerns to the surgeon or anesthesia provider right away. Patients have the right to understand what will happen and how to participate in their care. Teaching before surgery helps reduce fear, anxiety, and stress, and it can improve recovery and shorten hospital stays. Most patients receive this teaching in the surgeon's office or pre-admission clinic with a review on the day of surgery. Discharge instructions are essential, especially for same-day surgery patients. Teaching should focus on safety and include written materials for home use. Avoid overwhelming the patient tailor the amount of information based on their needs and readiness to learn. Anxiety can affect learning, so listen carefully and prioritize the patient wants to know. Pre-op teaching usually includes sensory info, means that the patient will see, hear, feel, and smell. Process info means general steps of the surgical experience. And procedural info means specific details about what will happen. Share teaching details with the post-op care team to ensure continuity and avoid repetition. Use a team approach to cover all teaching needs and document everything in the patient's chart. Consent for surgery. The surgeon typically obtains informed consent from the patient and addresses any questions they may have. But the nurse's role is to witness this consent process and sign the consent form as a witness. So NPO status. So the American Society of Anesthesiologists provides evidence-based NPO guidelines for healthy patients of all ages. For instance, preoperative fasting states that the minimum um, fasting period for clear liquids is 2 hours. And basically, the purpose of NPO is to reduce the risk of pulmonary aspiration and nausea and vomiting. Avoids before surgery. Encourage your patient to empty their bladder before administering preoperative medication and before transferring them to the operating room. This helps prevent accidental urination under anesthesia and lowers the risk of urinary retention during early recovery. So, preoperative medications. So, preoperative medications serve multiple purposes. Your patients may receive one medication or several medications in combination. Like, for example, benzodiazepines provide sedation and amnesia effects. Anticholinergics help reduce secretions. Opioids are administered to maintain and manage their pain and lower anesthetic requirements during the procedure. We can also give them antiemetics, which help prevent or reduce nausea and vomiting. So those are the pre-op medications that you may provide and administer. All right, so the last one is give a handoff report to the receiving nurse to ensure all essential patient information is communicated when transferring the patient to the OR. To prevent errors from miscommunication, it's recommended to use the SBAR model during the handoff process, situation, background assessment, and recommendation. Again, after completing all the pre-op intervention, we provide SBAR handoff to the OR nurse. Situation will be your patient name, age, surgical procedure, the surgeon, surgical site. Background example is a significant patient history, allergies, medications, and then of course assessment. It's going to be their baseline vital signs, any findings relative to the surgical procedure, any coping strategies, and then of course recommendation, preoperative care still needed, such as IV antibiotics, positioning concerns. So those are example of SBAR that you may provide to the receiving nurse. All right, so the next thing I'm going to be discussing about is intraoperative. So intraoperative essentially means during the surgery. So first, let's discuss the surgical team. So a peri-operative nurse is a registered nurse, of course, who works with the surgical team to implement the patient's care plan. So the role can expand three domains: preoperative, RN, and operating room RN or OR RN. And the last one is the post anesthesia care unit RN, also known as PACU. Post anesthesia care unit RN, also known as PACU. All right, so the next one is the scrub RN. So the scrub nurse follows the designated surgical hand asepsis procedure. So they are gown and glove in sterile attire and remain in the sterile field. So as a scrub nurse, you assume functions that involve sterile activities. Sterile activities. Such as assisting in the draping procedure and preparing the OR. Again, the scrub nurse always remains in a sterile environment. Okay. All right. So the next one is this circulating RN. So the circulating nurse performs all non-sterile activities. Sterile. So they help prepare the room by ensuring that supplies and equipment are available in working order and sterile. They monitor practices of aseptic technique. They also confirm that informed consent is present, that the patient has no unanswered questions. So while maintaining their position in a sterile field, they provide a handoff report or SBAR report to the PACU nurse. So that's the circulating RN. The surgical tech passes instruments and performs other technical functions during the procedure. The surgeon performs the procedure and is responsible for obtaining the consent form from the patient. And then the last one is the anesthesia care provider or the ACP. So the anesthesia care provider, like anesthesiologist or the CRNA, administers anesthesia and maintains cardiac and respiratory status intact throughout the surgical procedure. That ACP does not need to be sterile during surgery, just FYI. All right, so for nursing management, so during surgery, the perioperative nurses prepare the OR, wear surgical attire, must follow aseptic techniques, check equipment, scrub and glove, maintain a sterile field, understand anesthetic administrations or anesthesia administrations, assist the anesthesia care provider, prevent wrong side surgery, monitor the patient's temperature, and communicate the patient's status post surgery. So that's the nursing management for perioperative nurses. The last phase is the post operative care. After the surgical procedure, the patient's recovery is handled in the post anesthesia care unit, also known as PACU. The primary goal of nursing care in PACU is to monitor the patients for complications from anesthesia and surgical procedures. And the PACU is divided into three phases: phase one, phase two, and the extended observation. All right, so phase one is the initial recovery period. So during phase one, a handoff report or SBAR is done between the anesthesia care provider and the nurse. ABCs, of course, are the highest priority. That's your airway, breathing, and circulation. Make sure that your patient's airway is intact and they're still breathing. Watch their heart rate and cardiac rhythms and check their vital signs frequently, which include their BP, heart rate, oxygen saturation, and respiratory rate. So, at this phase, the patient is most prone to complications and requires constant monitoring. Here are some of the post op complications that might happen. The post op assessment you may include our management of their artificial airway, pulse oximetry to assess their oxygenation, watch their entitled CO2 or capnography to monitor their ventilation and detect any respiratory depression, continuous EKG monitoring for changes in their heart rate that may indicate pain or anxiety, bleeding, hypovolemia, or even like abnormal electrolytes. Frequent BP, vital signs monitoring, especially the blood pressure for complications for hypo or hypertension. Again, the vital signs monitoring usually done every 15 minutes in phase one. Also, frequent assessment of their circulation, including body temperature, capillary refill, skin color, and moisture. And lastly, frequent assessment of their neurological status, like level of consciousness, orientation, sensory, motor status, pupils. And one more thing, monitor their kidney status by frequently assessing intake and output and fluid balance. We can look at their kidney function tests and management of their IV fluids and medications as well. So, the goal of phase one is to prepare the patient for phase two. In order for the patient to move to phase two, the patient needs to meet the discharge criteria or the DC criteria. Okay. So the patient should be hemodynamically stable, which basically return to their baseline blood pressure and heart rate, or near the baseline, return to their baseline mentation or neurologic status, adequate urine output, um, surgical site dressing is without any excessive um, drainage. Tubes or drains are draining the expected color and consistency of drainage and expected amounts. There's no respiratory distress or depression. Their oxygen is greater than 90%. Pain is managed, and the patient reports pain as tolerable. Of course, there's no nausea and vomiting, and S bar is received. Okay. So phase two care is in an inpatient setting. So the nurse focuses on preparing the patient for managing care at home or in an extended care environment like rehab. The patient should meet the ambulatory surgery discharge criteria before sending them to home or extended observations. So, what are those criteria? Well, these criteria are, which include all PACU, all PACU discharge criteria met, DC criteria, which is phase 1, met. No IV opioids drugs for the last 30 minutes. So no IV opioid drugs for the last 30 minutes. Number 3, voided if appropriate to surgical procedures or orders. To surgical procedures. For able to ambulate if not contraindicated. And then 5, there is responsible adult. Present to accompany and drive the patient home. And then the last one is a written discharge instructions given to the patient or caregiver, and understanding that they confirm and understand the discharge instructions. Okay. All right, so the last phase is the extended observation. Patients may need to be transferred to an extended observation area, such as rehabilitation facility, or they may remain in an inpatient unit for rehabilitation, especially if they have like hip surgery. So again, nursing care continues to focus on preparing the patient for discharge and self-care.